So next up, Professor Clark. So Julia is a paediatric infectious disease specialist at Queensland Children's Hospital in Brisbane, and is Director of Infectious Diseases, Immunology/Allergy and Rheumatology at that centre. As an experienced full-time clinician with strong commitment to clinical research, Julia provides specialist support for infections in immune-compromised children and leads the infection control, antimicrobial stewardship, antibiotic-related guideline and policy development and implementation at that centre.
All right, so I'm the token paediatrician. Hi, everybody. Fabulous to see everybody, and I'm delighted to be talking about my favourite virus, adenovirus. It's the gift that keeps on giving. So I'm going to have a little whip through, just taking you through a little bit of adeno and then thinking about adeno in children, obviously, with a little bit of translation, I'm sure, for adults. So as I'm sure you all know, adenovirus has got multiple types, and the species in relation to types is something that it's very helpful to get our heads around, particularly when we're thinking about testing. So I'm just going to talk to that very slightly. So there's adenovirus species A to G with lots of different types, and the number of types is increasing as molecular diagnostics improves, and phenotypes do depend on organ tropism and the adenoviral type that's infecting you. And again, that's important. So the numbers may relate to species, and species obviously relates to numbers. Different adenoviral types do give you a different clinical phenotype, and the clinical phenotypes are hugely variable. The things that we see in children, just with adenoviral, normal immunocompetent children and adenoviral infection, include eye, so conjunctivitis and pink eye, lots of upper respiratory tract infections, a few lower respiratory tract infections, and lots of GI infections. Occasionally, we get cardiovascular and myocarditis, but that's really about it. Within the immunocompromised, all of those things also, but particularly lower respiratory tract infections and GI infections. There is some work done on looking at adenoviral types in association with particularly pediatric bone marrow transplant. And historically, C1, C2, and A have been pulled out as being associated with disease, so disseminated disease within transplant. And there's also an association, really within small case series, remember, that C species may be more associated with severe disease. It's really important to remember, though, that F, or F and G, but F4041 is really a GI pathogen, and it very rarely, if ever, disseminates. So there is one case report of disseminated CNS disease with 4041, but there's very little else. And so very rarely does it disseminate. There's always exceptions, and so there's never a never, but it's unlikely. Others will. So we've just got some a little bit of studies going on and looking at adenovirus within our bone marrow transplant, pediatric bone marrow transplant population. And so over the last 2 to 3 years, we've been trying to collect all of the adenoviral positive PCRs and look at both genotypes and looking at different compartments, which I'll come to. And so just as a very quick snapshot, we haven't related any of these to severity yet, but our spread of types is a couple of A12s, several Bs with various different types, and 4 Cs, C1 and C2, so close to the literature. And the reason that that's important is really thinking about the testing, because not all adenoviral tests are the same. And when you look at the literature, particularly historic literature, it's much better now as there's much more concordance with adenoviral testing. But previous literature, when you look at adenoviral PCRs described, the adenoviral PCR used may be wildly different between studies. So some PCRs early on looked at just specific type A to E and excluded F. Some looked at just known adenoviral types, but more recently, most adenoviral PCRs are commercial PCRs, which look at pan-adenoviral. But it's worth remembering that as you look at the literature. And different places, so different laboratories will use different testing for stool. So some will use a pan-adenoviral PCR, some will just look at they shouldn't be looking at excluding F, forget that, but some will just be looking at type 4041. And in fact, here at QPath, if you just do a routine stool viral screening, you will get a 4041 and not a pan-adenoviral PCR. Again, worth remembering for the next part of what I'm going to talk about. And then quantitation, and there's been some talks already thinking about particularly HHV6, for instance. What do we do about testing and quantitation? So is this, do we use an in-house or a commercial kit? Are all the types included within a quant? Can you compare them between centers? And the viral kinetics are really important when you're looking at any viral disease. So knowing what you're using and what quantitation means and how it's been done is also important. So what about pediatric adenovirus within the transplant population? So I've got some figures here which look at the literature as a whole, and the figures in red with the brackets there are our own local figures. So we looked at our experience within about 450 pediatric transplants from 10 or 15 years. Robin Silcock, our current ID fellow, has put them all together, and we published them a few years ago. And we looked at viral infections as a whole, so viral reactivation, so any detection of a virus during that transplant time. So the figures in red are our adenoviral figures locally in relation to the literature as a whole. So adenovirus is frequently detected as a one or more PCR in pediatrics. So about a quarter of patients may well have an adenoviral PCR positive during their transplant period. And the mortality associated that can vary hugely, again, depending on the year and the studies, but up to 50% of infected patients may have a mortality. But adenovirus as the cause of death is obviously much lower, and generally has been estimated about 2 to 6%, and our mortality indeed was about 6%. Risk factors for adenovirus, very similar to risk factors for most viral infections. So the younger age, the time to immune reconstitution, the donor type, particularly T cell depletion and cord blood, cord mismatch of cord blood, severe GVHD, and quite nicely associated severe lymphopenia. So anything less than 0.2, significant risk for disseminated adenovirus. And conversely, and logically, survival from adenoviremia is associated with a lymphocyte count of more than 0.3. And I mentioned that viral kinetics are important, and there's quite a lot of case series and studies looking at how virus quantitation and the quantitation over time. So you can often detect viremia before you detect symptoms. This is before in historic studies, before active intervention was started quickly. If you detect a viremia over a particular viral load before disease onset, there's a threshold before you get a disease appearing, and very high viral loads and rising viral loads, or interestingly from studies in the UK recently, an area under the curve that is accumulative viremia are very much associated with developing disseminated disease and significant outcomes. And again, conversely, decreasing viral load correlates with survival. It's logical. One of the interesting things that is a big discussion point within pediatric transplant at the moment is that fecal viral loads are postulated as predictors of subsequent viremia. And that was documented and illustrated by Leon from France some time ago, but there's a little bit more interest again, and there's a few centers looking at this actively. And I'm just going to go into that in a little bit more detail. So this is, if you want a paper to look at that gives a fantastic overview of adenovirus, it's this Leon paper from Clinical Micro Review from some time ago now, but it's a really good paper looking at adenovirus as a whole. And this graph really nicely illustrates fecal viral load increasing before viremia, adenoviremia in the blood. And they calculated a threshold of fecal viral virus load that would predict viremia. And that was, 10 years ago now. And then more recently, a group in the UK from Manchester have also done a very similar thing and suggested that a threshold, a fecal viral threshold of a log greater than 5 log 10 predicts adenoviremia in pediatrics. And that in cancer patients, rather than non-malignant diagnoses, there is a sensitivity and specificity, which is nearly 90%. So a relatively good sensitivity and specificity. And that onset of viremia is 8 days, a median of 8 days after your threshold of fecal viremia, fecal viral detection. And that, again, slightly logically, viremia is associated, significantly increased in patients, but not in patients just with reactivation in feces alone. This has been discussed, and we are, have been looking at this and interested in this for some time. The limitations that are not well brought out within these studies are really within that adenoviral type issue. So what are they testing? So presumably most of them are testing adenoviral, pan-adenoviral PCRs within the stool. But what is the significance of a 4041? Does that confound that? And that hasn't really been pulled out. And I was interested, and we're interested in our group of patients to look if there's any discordance. So is it the same type, adenoviral type, that you get in your stool when it's reactivated as in your blood? It should be, but is it? And for the small amount of patients that we've got so far, where we've got adenoviremia and stool viruses to compare, there is discordance in a quarter of those, 1 in 4. And I just wanted to show you the breakdown of reactivation and mortality for the 445 cases that we looked at, and compare the adenovirus figures really with other viruses, so CMV, EBV, and HHV6. So we're detecting adenovirus as much more frequently than other viruses, but mortality is less than CMV, which is a historic mortality, remember, as well, but similar to other things. About half the patients will reactivate, and only half of will reactivate and disseminate, so half of them won't. And only about a quarter of them had one single positive adenovirus. So it's very important to make sure that you're doing serial adenoviral testing, which we all would do. We gave some cidovovir. We had a couple of patients that got some brincidovir as compassionate use, and 2 patients had some adenoviral specific T cells. But we could pull out some risk factors which are consistent with the literature and the evidence. So viral dissemination for risk factors for aggression and mortality, presence of GVHD, and a longer duration of persistent adenoviremia. Now, I'm not sure whether this is going to work. When I came back from some leave on the weekend, so Sunday night, I'm on a plane, long haul, getting very bored, found some TV series, The Cleaning Lady. Anyone ever seen The Cleaning Lady? And I was also started to think about this talk and what I'm doing this week. And I was just so excited to get to episode 2. And I have got this clip for you, and I hope it works. Doesn't matter if it doesn't. But apparently, according to The Cleaning Lady, cidovovir has proven success in immunocompromised children.
No, it means your body's talking to mommy. She's got conjunctivitis, fever, pneumonia, and now pink eye. It has to be adenovirus. We have to treat him now.
Treating adenovirus without confirmation is too risky. It could be toxic to his liver, kidneys.
Cidovovir has proven success in immunocompromised children.
But if we're wrong, he could end up with organ failure.
And if we wait, he might not make it at all.
So there you have it. The rest of the plane didn't know what I was laughing at. So adenoviral treatment. 2 treatments have been traditionally reached for. I'm not sure about how many people here in this audience have used ribavirin. Some of us who've been around for a while have. It's useless. There's little evidence for efficacy. It's generally not recommended, but it's still sometimes used. And you need to know what the species is if you're going to use it, because it only has activity against species C, and we're not all, as I've just mentioned, it's very rarely that we will be looking at specific types and getting that answer. Cidofovir has got efficacy against all species. It's been incorporated into treatment protocols for adenovirus infection across all guidelines without any randomized controlled trials or clinical trials. There's lots of case series with small numbers, particularly small numbers in children particularly. And looking at how you respond to cidofovir is really confounded by T cell reconstitution. So it's difficult to know how much it contributes and how much it doesn't. It's got poorer bioavailability and got a renal toxicity. The renal toxicity is probably less in children than it is in adults, I suspect. Does it really work? Those of us that work clinically may have our doubts, and I'm not sure how much it does work, but we will use it. This, however, was quite a nice paper that tried to pull out that issue of the confounding factors with T cell reconstitution, because you will be giving cidofovir generally when you get adenovirus during the time of T cell reconstitution. And so it may just be that that's affecting it. Well, this study managed to pull out 20 patients where viremia was controlled in the absence of T cell reconstitution. But when they say controlled, it really kind of means it didn't get worse, but it didn't really get better, I think. So I think the jury is out, but it is very much embedded in our treatment algorithms. Brincidofovir, those of you who have had the option of using it until we can't guess anymore, does, however, interestingly, have not only case series behind it, but some trials. And so there have been a few trials, many of which have not managed to reach publication. So there's 22 trials that have been registered on the registry and about 7 published trials or studies. I was going to just give you a little bit of more detail about the adenovirus HALT trial, which is a randomized placebo-controlled multi-center phase 2 study looking at the safety and efficacy of brincidofovir for the prevention of adenovirus disease in both children and adults. And so there was 48 subjects, both children and adults, randomized to twice weekly brincidofovir, BIW, or once weekly brincidofovir, BCW, or placebo with a, I think this is a very odd way of displaying your results, treatment of failure rather than treatment success. So treatment of failure was less in those that were given twice weekly brincidofovir. And those, in a post hoc analysis, again, very interestingly, those who have a higher viral load, brincidofovir achieved an undetectable viremia in 86% of subjects, as opposed to 25% in placebo. So there is some evidence around brincidofovir. And there is also some quite nice case series, again, looking at rescue treatment and comparing to cidofovir. So this plot on your left does show rescue treatment of brincidofovir after treatment for children with cidofovir, with a significantly decreased viral loads within those children that failed cidofovir. And the graph on the left is one of our single experiences. You know, n equals 1 in everybody's life, doesn't it? This child had an increasing viral load with cidofovir, was given brincidofovir at the red arrow, and the adenoviral PCR decreased significantly. It's just a great shame that brincidofovir is licensed for smallpox, very useful, and is being repurposed for monkeypox, which is great, but is difficult, if not impossible, to get currently. The last little bit of treatment that we are all aware of is T-cell immunotherapy, and this table is taken from a review paper from some time ago. There isn't a huge amount more studies to put on that, but in total, from a review paper just this year, There's about 65 patients had published experience with T-cell immunotherapy, with a published good response and a low rate of GVHD. There are currently ongoing prophylaxis trials, not just treatment trials, some of which are being driven out of QIMR and are within the pediatric population. So finally, what do you do? There's lots of these algorithms that you'll see. How I treat adenovirus, what do we do? This is one similar one that I thought was relatively sensible and sensible because it equates with my personal practice. So that's obviously sensible from last year. So if you've got a high risk patient who's high risk for the reasons of their donor and their T-cell depletion or their previous past medical history, monitor them. And in pediatrics, we've got the option potentially of still monitoring, although this isn't yet in routine practice within our centre, certainly. And you would continue monitoring depending on their reconstitutional lymphocyte count, and then would have an option if getting early detection to start cidofovir or with reduce or withdraw immunosuppression. With disease progression, then adoptive immunotherapy should be sought. And I'm going to stop there just finally with, apparently this is a dog with adenovirus. Thank you.
Thank you, Julia. I know we're running late, but it is really interesting stuff. So I'm just going to still open it up for questions. While people are thinking, the risk factors clearly for adenovirus overlap with lots of other viruses, as you pointed out. Particularly in the pediatric population, do you see concurrent viral infections going together? And as adeno and CMV, adeno and HHV6?
Yeah, absolutely. So adeno and CMV, and with adeno and CMV, and with when we look at that, we can we often see dual infections, but what we often see is that one then becomes the predominant one. So usually adeno and CMV. That is.
Jason?
Julia, I'm going to ask a pharmacist question about the use of probenecid with cidofovir. Is that something which you're doing at Queensland Children's Hospital?
Yeah, so that goes, that's kind of almost a given. So the protocols always embed probenecid with cidofovir.
So in which situations would you not use probenecid?
Never.
So it's always that second line of dosing, the old alternate day dosing that you would use.
So we'd always, well, not never. So it would depend on the stage of transplant, the comorbidities, and what else the pharmacological pressures there were.
Great, thanks.
So we might end it there because we have a panel coming. So thanks very much, Julia.